How's it going, guys? We have a past little question pharmacology. 29-year-old dude, he has HIV, and he also has pancreatitis. We're not making that confusing. We're saying he has abdominal pain radiating to the back, acute history. The methadone program, so this just means he's an IV drug user because methadone used to come off opioids, heroin, fentanyl. And if you have amylase lipase greater than 3 times the upper limit of normal, that's pretty standard for diagnosis of pancreatitis. And which agent is most likely responsible? Choice A, adenosine, correct answer. So it's buzzy that you know that one of the NRTIs, nucleoside reverse transcriptase inhibitors, adenosine, it can cause pancreatitis. It's about 7% of people who take adenosine get pancreatitis, and USMLE assesses it. Nucleoside reverse transcriptase inhibitor means that it's a sugar, a ribose, and a base, the structure of the medication, and it can interfere with the RNA-dependent DNA polymerase because it's a reverse transcriptase. Okay. In contrast, efavirenz, wrong answer, is a non-nucleoside reverse transcriptase inhibitor, NNRTI, which means it doesn't have that same structure. But efavirenz is one of the 2 medications you need to know that causes wild dreams, vivid dreams. Okay. The other medication for USMLE is varenicline, which is a nicotinic receptor partial agonist that's used for smoking cessation. Wrong fucking answer. Choice C, ritonavir, is wrong. So the navirs, these are protease inhibitors. These can cause Cushing-like presentation. That's what you need to know for USMLE. So hyperglycemia with insulin resistance, they can cause fat redistribution. Okay, so any patient who has HIV, who has a Cushing-like appearance, the assumption is that they're on a protease inhibitor as the cause. Wrong fucking answer. Choice D, and also ritonavir, it inhibits P450, so it's known as a booster medication. So patients who are taking other medications, let's say for tuberculosis at the same time, they can have reduced doses of other medications if they're simultaneously on ritonavir. Bit bizarre of a factoid, but it's known to be assessed. As I already said, wrong fucking answer. Choice D, TMPSMX, is wrong. So just overall important medication you know that is brought in under a CD4 count of 200 for pneumocystis jirovecii prophylaxis. It's also the treatment. Okay, so toxoplasmosis, which comes in at a CD4 count of 100. TMPSMX is coincidentally also the prophylaxis. So it's 2 birds with 1 stone when you start this for PJP up at 200. However, the treatment for toxo is sulfadiazine pyrimethamine. TMPSMX can be used for things like simple UTIs as well, and sometimes skin infections. And not only can you get sulfa allergies because of the sulfa component here, but also neutropenia, mouth ulcers. Wrong fucking answer. Choice C, zidovudine, wrong answer. So this is one of your NRTI similar to adenosine, but it doesn't cause pancreatitis classically. Okay, so you can get lactic acidosis, you can get general bone marrow suppression. Zidovudine is also the one that you give to pregnant women at parturition who have HIV to decrease vertical transmission. It also shows up on one of the pediatrics forms for the answer that you give to neonates within 12 hours of birth. Okay, so to decrease vertical transmission, you make sure the mother is on HAART therapy, highly active antiretroviral therapy, which is always 3 drugs for USMLE. And also you do C-section, and you give zidovudine within 12 hours of delivery for 6 weeks. Wrong fucking answer.